us there. Alrighty, I'll turn it over to Christina for our didactic.
All right, thank you so much, Troy. We do have just a little less than 20 minutes, so I'm going to go through some of the slides. I believe these will be available to folks too, so some of the resources and things. I always like to try to include a lot of resources so that you have something to take with you. A couple disclaimers here. I think we've already kind of worked through that, you know, these things. Just if you do provide any case studies in the future, just again, remembering not to disclose PHI. You are signed up for that. Our team members, of course, Melissa, Jennifer, and I. And then just a quick disclosure, you can read that. Basically, none of us have anything to disclose. So today we're going to get into screening. Last week we talked about SBIRT overall and just kind of a general overview of what those letters stand for. We definitely want to start that screening process encouraging people to be honest. And in order to do that, we have to create really non-judgmental spaces, especially when we're talking about women who are pregnant, may become pregnant, the stigma that may be around talking about substance use in those situations. So some of the objectives, you can again read through these, but basically we're going to look at some of the tools and then how do we make sure that we're conscious of some of that bias, especially regarding pregnant women who may be using substances, and how do we deal with that? So just want to remind folks that words are important. As always, we want to create a non-judgmental space for participants. Some of the words that we might use, so saying things such as a UA was positive or negative, just stating a fact. I know I worked in a medical setting for over a decade, and I'm sure I said it. I'm sure I referred to somebody's UA as dirty at one point, not thinking about the implications of that. Now I'm very conscious of the words I use because it does imply a judgment. So instead of saying something was clean or dirty, just simply it was positive or negative. Again, as we refer to individuals, whatever disorder they may be presenting with, we always want to be person-centered, client first. So just really understanding, again, the words that we're using. Maybe this could be something we talk about in staffing. We start to create that culture amongst those we work with so that when we're speaking in front of our clients, participants, or patients, we're very aware of the terminology that we're using. So this is just some more examples of some maybe more stigmatized language and some non-stigmatized language. So just again, being very conscious of the words that we're using. So I'll give you just a moment to read through a few of those. And again, you can go back to this PowerPoint will be available, so you can go back and look at a few of those. I love some of the information from Johann Hari. I don't think we're going to have time for it today, unfortunately, but this link is in here. Johann Hari is a researcher. He presented at the National Conference for Behavioral Health in 2019. This is a particularly great talk. I would highly recommend that folks go in and watch this. If you just type into Google Johann Hari, NatCom 2019, it'll come up. It's a YouTube, so it's something that I think it might be important to view. I've used it with individuals in training, with staffing. I think you could use it with participants or with patients, clients, just to talk about our view of substance use and how other countries view it. And I think one of the most profound statements that he makes in this video, particularly, he says, the opposite of addiction is not abstinence, it's connection. And I just think that's so profound. And usually when I show this, that's kind of what resonates for a lot of people, that sometimes in our treatment, we've disconnected people because of requirements, or we say, you know, if you come back with a positive UA, then we can't provide you treatment, those kinds of things, and how that may have set up individuals to be even more disconnected at times. And so really the key here is connection, and how do we, again, view this major issue in our society. So again, I wish we had a little more time. I'm going to move on, but I would again highly recommend you going back and taking a look at some of his stuff. He also has a couple of videos, but also a book called Chasing the Screen that's very good. I also love that it's very evidence-based. So screening, if we're going to look at screening, one of the things we want to do is we want to have standardized tools. That's really important. I know I've talked with some groups that say, yeah, we're screening, that's all. And I'm like, that's awesome. And I'm like, what validated tools are you using? And they're like, we're not. And so we want to make sure we're using standardized validated tools that are out there. They're quick, easy to score. We want to screen everyone at that universal level. So again, we're giving this out to everyone. I could even think, Colleen, even in this situation, maybe like doing a screen with that individual that you were talking about, going over the high risk limits, really connecting it to health, all of those goals that that individual has in the future. This is a great way to connect it to health. If she wants to have a baby in the future, those kinds of things, it'd be a great way to just talk about that matter of fact. That these are the ways that alcohol affect your body, and did you know that? And do you mind if we have a conversation about that? So when we look at the low risk drinking guidelines, this is something interesting. In about 2012, I was exposed to SBIRT at a conference in Chicago. And I thought, man, I've been in the behavioral health field a long time and I've never seen this. And why? Why is that? Why have I never seen this? So I try to share this far and wide. You can find these in a lot of different forms. It's a great thing to maybe have a poster of that's up in our lobby, or maybe sitting in the bathroom. Bathrooms are always a great place to put posters, I think, because they have some time. We're sitting there, we'll look at stuff. So we want to take a look at those levels, and we want to have conversations with individuals. For men on a single day, it's no more than 4 drinks a day, and that's a very important conjunction there. No more than 14 drinks per week. And then for women, no more than 3 drinks per day and no more than 7 drinks per week. And this comes out, a lot of different agencies, World Health Organization, different entities have kind of come together and said, we need a standard. We need to just present the same information. So that if you go to the doctor, the hospital, the clinic, your behavioral health provider, they're all kind of given the same information. The one thing we want to point out here, that women who are pregnant or may become pregnant, of course, should not be drinking alcohol. We just don't know what level, what point in pregnancy that's going to have an effect. And so we want to make sure that we're giving people this information. We're giving them good, validated information so they can make an informed decision about what they put in their body, right? We want to make sure that they have that information. So this is an example of a universal screen. This is something everyone gets. The audit C is used pretty regularly. Again, if we're screening, and just to identify if someone tests positive on an audit or on a universal screen, then we do a full screen. And that full screen is still going to be, 6 to 10 questions, maybe a few more, depending on which screening tool we're going to use. So for example, yes.
Christina, real quick question here from Dr. Bion. Could you define drink for us?
Absolutely. That is a great question. I love it. I love that you're thinking about that. So for a drink can be defined as 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of distilled liquor. So you can find those, and that's so important. And I usually include it in my slides. We're trying to keep this really time constraint and make sure we get you out of here on time. But that's such an excellent point, is that as we talk about these drink limits, we really need to define what one drink is. Because if I used to have these conversations a lot with individuals come in my office, and I'd say, how much you been drinking? They were like, oh, just one, right? Well, they didn't tell me it was like the 54-ounce bubble keg, right? And if I just ask how much you've been drinking and they say 1, that's really not that great of information for me to have. So thank you for that point. We absolutely need to define that. A lot of these posters that you'll find actually will have that on it. If you go through some screens like the audit, it'll have at the top, and it's something to think about having as a definition of what one drink is. So thank you for that point. I really appreciate you bringing that up. So for individuals who are identified coming into and receiving services that are pregnant, this is a tool that we might use. There's a lot of different screening tools out there, but the 5 Ps is nice because it's a behavioral health screening tool. It includes not only their substance use, but also really checks in on if there's any their emotional health and any violence. So this might be something that we could consider, and individuals may use in this type of a setting to really identify. The thing here, and I know I've said this last week, I just want to really emphasize this point, is that if we're going to ask these questions, we really have to be prepared that people are going to say yes. And then what do we do? So we really have to be mindful and thoughtful about implementation processes, which we'll get to as part of this series in one of our later weeks. That's a little teaser for you, so you make sure you come back. But we want to make sure that we're planning for that. That when that happens, not if, but when people start talking to us about these things, we know that we can do a brief intervention, whether that's towards reducing use or intervening, or doing a brief intervention to help someone to accept that referral on to more specialized care. So depending on our setting, we may be able to identify and treat that within our agency or maybe under one roof. I live out in Western Kansas, a pretty rural area of our country, and to have those providers all under one roof would be, wow, that would be amazing, but probably not very likely. So we're going to have to be very creative on how we're doing those referrals. But screening is the first step. It's not the only step. And that's the other emphasis I want to make here. That brief intervention referral to treatment is integral in the process of really providing SBIRT services. But we want to be mindful too on the screens that we choose. We want to make sure that we have buy-in, that we have good buy-in from our whole staff, that we're conducting annual screenings. If we think about this, put it in medical terms, we do this for a lot of things, right? We do this for blood pressure. I can go to Walmart, I could stick my arm in a cuff. Well, I could 8 months ago. I don't know if they still got it open, but I could stick my arm in and it would take my blood pressure. Every time I go to the doctor, they take my blood pressure. And then if it's, something's positive or something's high, there's more in-depth assessment, right? And then they make the recommendations based on that. We can look at it the exact same way. We can start to look at this screening for substance use as we're just going to do this. It's part of our services. It's part of their overall health. As has been mentioned, Colleen, this is a great case that she presented today to know we can try and treat this over here, but if we're not addressing the substance use, that's kind of getting in the way of any treatment we're going to provide. So we've got to start talking about it. We've got to start addressing it. So what screening does provide is it's looking at risk. We're really just trying to identify a risk. We're not doing a diagnosis. This is different than a full assessment. This is just asking some questions to assess risk. It's going to provide a context for discussing this. We're going to, maybe suggest areas where this use or those psychiatric symptoms may be problematic. We're going to identify patients most likely to benefit from brief intervention, and then also identify those that need that referral on to more specialized care. Some things that we need to consider: we need to look at protocols. We need to look at scheduling, staffing, training. How are we going to implement this? What are some policies? We need to have policy in place because reporting is going to come up. If we're screening for individuals who are pregnant, there's legal implications of that, right? And we need to know that. We need to have informed our participant about that before we start asking those questions. Because one of the things I want to know, do you know the regulations regarding mandated reporting of substance use during pregnancy in your state? So I know some of us on the hub team are in other states. Those of you that are in Nevada, just a quick poll here, and I'll have Troy put that up. So just, do you know what it is? Yes, no, or maybe I need to look into that a little bit more. And don't forget to push submit there at the bottom. And I think, Troy, if we can go ahead and post that, maybe we come up with.
Yeah, maybe just one more second here for responses.
Okay.
All right, I'm going to go ahead and end it now. So 17% say yes, 33% say no, and 50% say need to look into this some more.
Okay. So again, if you put no, or I need to look into this some more, or yes, the point of this is that we need to know. We need to know if we're going to start screening, if we're going to start asking these questions, we need to know if answers to these questions will then, result in a possibly, we're going to have to make a report. So one of the places that we can look, there is some information out there. You can talk with your local representatives, your human services, child and family, those sorts of resources. The other thing is there's this Guttmacher.org. They do list by state some of the state policies and explore that. They keep it very up to date. They also give information on advocating. So a big advocacy movement right now is that we don't want to prevent people from telling us the truth and from accessing care. And so if we have laws and regulations that mandate reporting, we want to make sure people are safe. We also want to make sure that people can be honest. And so this is a great resource. I take you to it. I think Nevada. So what is the consensus? Do we know Nevada? Is it considered child abuse if people are using substances during pregnancy? Could we answer that?
No. In the state of Nevada, NRS doesn't deem that child alive until after they're born.
Okay. Okay. So again, that it would be good to look into that. If you're going to be screening within your agency, that's very important information for clinicians to know, because if most clinicians are individuals that are in those positions to process through and go through providing SBIRT services are going to need to know and are typically mandated reporters in that situation. So very important that we find that out. I'm going to go back to sharing my screen, just have a couple of other slides. I want to make sure, be conscious of your time to get you out of here. The other thing we need to make sure of is cultural implications. Again, in screening, finding screens that if we provide, for example, a lot of services to Spanish-speaking populations, it'd be very important that we have screens in Spanish. And also take into account other cultural implications, other beliefs that may affect our understanding of someone's use of substances. So some resources, again, I try to pack this with some resources. Right now, the state targeted response through the Opioid Response Network, there's a lot of information, technical assistance if your agency is thinking about implementing these services. Tons of experts across the United States. You can email them, give them a call, and they can provide technical assistance and training. Also through, there's tools for treatment. This is a family-centered behavioral health support for pregnant and postpartum women. This was brought about by Mid-America ATTC. Region 7 has a ton of resources out there for individuals. So you could take a look there. As well as Postpartum Support International. I know this is Melissa. I don't know if you want to speak to that. I know you do a lot of work with them. Could you explain? Sorry, I'm putting you on the spot here, but maybe explain a little bit what they do.
Sure, no problem. So I'm the president of the Kansas chapter, and we have several chapters throughout the U.S., but Postpartum Support International is an international organization that provides perinatal peer support and resources to families wherever they are. So they offer a warm line, they offer free support groups. There is not a perinatal substance use support group active right now. However, that is coming. But we have support groups that are free on a variety of topics: military, families, perinatal or pregnancy loss, postpartum specifically, pregnancy specific, perinatal specific. We have a father support group. So a lot of different targeted populations, and all free and run through volunteers in the state who provide support as support coordinators for their areas. So happy to be contact if anybody wants to learn more about that. And in Nevada, you do have an active group of Postpartum Support International volunteers.
And Melissa, did they still have the provider line?
Yeah.
Yes. So yeah, I think that's really important.
Yeah. So from the standpoint, we also have a provider consultation line. So if you are a provider who does not regularly do psychiatric care, especially perinatal psychiatric care, you can call and set up a consultation that's free to you with a reproductive psychiatrist, and get some guidance on a particular case. So most definitely happy to give you more information. It's all on the website. If you go to providers, that tab, you'll see all these things listed. But happy to be a contact if you have additional questions about that.
Okay, thank you, Melissa.